is the palatine artery. The palatine artery is usually located between the second and the third molar. Okay? And why, when this anatomical structure can be injured? When we deal with really atrophic skulls. So the palatine foramen is at the level of the coronal bone. So in these cases, the palatine artery can be injured, but not with the implant. You know why? Because to enter inside the palatine foramen, we have to tilt the pterygoid implant vertical, okay, going vertical and 45 degrees toward medial. But what do we have that limit this angulation 45 degree vertical and toward medial? We have the cheek, that is a strong barrier. Okay, so you have not to be afraid about the palatine artery, except when you have really resorbed skull, really atrophic maxilla, while you raise the palatine flap. So how do you raise the palatine flap without injuring the artery? Pushing distally, like in the video Matteo, it was really interesting to see the palatine artery, and pushing measurably, like when you have to uncover the metal foramen. It's always the same. Don't push with the elevator directly against the palatine artery. Okay? Another plexus that we can injure is the pterygoid venous plexus, but it is really lateral between the buccinator and the lateral pterygoid muscle. So even if you do distal vertical release incision, you can have a venous bleeding from there, but if you're packing with a gauze, because it's venous, so it's low pressure, it's not a risky anatomical structure. Okay? So now we know perfectly the anatomy in which we are dealing with pterygoid implant. So, which will be the inclination of the pterygoid implant? The pterygoid implant has always the same inclination, from medial to distal, and from lateral to medial. Why from medial to distal? Because we have to overcome the posterior recess of the maxillary sinus, and we have to reach the pterygoid fossa, that is the most posterior limit of the maxilla. Okay? And why from lateral to medial? Because the pterygoid fossa is always more medial than the distal aspect of the tuberosity. Remember this word, from medial to distal, from lateral to medial. Because next week, if you are in your office drilling and doing an osteotomy for a pterygoid implant, and you are not from lateral to medial, you are doing a mistake. So remember my words, from lateral to medial, from medial to distal, because it's always, always, always the same. Okay? So let's analyze the CBCT, because we have to understand also from a radiological point of view how to put and to plan a pterygoid implant. So, going cranial, we start to see what? The tuberosity. And how do we recognize a tuberosity in the CBCT? Because it is a low density bone. And how low density bone appears in a CBCT with a dark color, because they have really soft bone. Then going cranial, we start to see what? The laminas, okay, of the pterygoid, the lateral lamina and the medial lamina. And between the two laminas, what do we have? The pterygoid fossa. And inside the pterygoid fossa, that is our target point, so we have to enter inside the pterygoid fossa, we have the muscle. And the muscle is not a risky tissue for the patient, okay? Because it doesn't bleed, it doesn't happen anything if you injure for a while the pterygoid muscle inside the pterygoid fossa. Then going more cranial, we start to see what? The entrance of the pterygopalatine fossa, where we have the artery. but it's really in a total country, in a totally different country. It's like speaking Italy and Vietnam, they are really far. Okay, so it's really difficult to enter with the bar inside the pterygopalatine fossa. Or you use a zygomatic bar, or with the normal bar, it's impossible, even if you are doing a wrong inclination. Then with the coronal views, you see what? You see the tuberosity, and up to the tuberosity we have the maxillary sinus, okay? Then going more distal, we start to see medially the channel of the palatine channel where we have the palatine artery. Then going more distal, we start to see some white bone, and the white bone represents the pyramidal process of the palatine bone, where the implant will get stability. Then going more and more distal, we start to see the pterygoid fossa, our target point. Okay? So let's analyze this clinical case. This is the common clinical case that everyone in the world has in his office. A patient that is asking for what? For the rehabilitation of terminal dentition only in a quadrant. So a partial rehabilitation, not a complete rehabilitation of full arch. It's the patient that is asking us, oh doctor, I have mobility on this tooth. Can you do something maybe with the medial loading because I don't want to do? Or better, you offer to the patient, okay, we can regenerate the defect, maybe with a Fourie technique, beautiful technique, very difficult, okay? I'm not a good or the best surgeon. I am only a medium skilled surgeon. So for me, regenerative surgery is a big effort. Okay, so I want to do something more easy. I want to use all the available bones. So I start to analyze the CBCT. I have possibility to put an implant here, and maybe to put a pterygoid implants posteriorly. So I have all these bones. So I do my surgery, okay, simple flap, simple crestal flap, going from the distal aspect of the tuberosity toward the mesial distal aspect of the canine. I do a post-extractive implants here in the premolar, and implants here with a big cortical anchorage with the maxillary sinus, and the pterygoid implants posteriorly, okay? And why pterygoid are so special? Look what do they have. Look the field in which pterygoid implants are placed. We have a lot of keratinized tissue and a lot of connective tissue. So having a lot of this tissue, we are creating a field where the implant will have a long-term survival. Because everyone wants around our implant can connective tissue and keratinized tissue. And look at the inclination of the implant from medial to distal, from lateral to medial. Okay? And this is the final OPG with the final CBCT, because this was one of my first pterygoid implants, so I wanted always to check if the implant was in the right spot, in the right place or not. Okay? So even if we plan a pterygoid implant guided with the digital technology, always follow the scheme, okay? From medial to distal, from lateral to medial. And have we to do big cortical anchorage, so entering inside the pterygoid fossa? Yes, we have to do it. Nothing happens. So when you drill for a pterygoid implant, the sensation, the feelings are always the same. We feel soft, then we start to feel hard. It means that we are going against the cortical bone, and then we fall down inside the fossa. When we fall down inside the fossa, it means that this is our arrival point. It's like when before Matteo was showing to you the osteotomy zygomatic implant. He enters inside the zygoma. When he goes up, he it goes outside the zygoma, it's the arrival point, the length of the zygoma. For the pterygoid, it's the same. Big cortical anchorage, entering inside the fossa, entering inside empty space. If we feel, for example, soft and then empty space, it means that or we are too vertical, so we are going inside the maxillary sinus, or we are going too lateral, toward the infratemporal fossa. Okay? So remember, soft, hard, and we fall down. Okay? Always, always the same. Always, always the same. And we have to plan like that. Okay? Entering inside the pterygoid fossa from the coronal and the sagittal point of view. Let's see this clinical case. Okay? As I told you, I'm a normal dentist. Okay? And this patient asked me for a solution. She had a failing dentition of the first and second molar. The second premolar was okay. So I told to this woman, do you want a bone regeneration in the posterior area, waiting for 9 months, and then having two implants, and these 2 implants we wait 3 months, and after almost 1 year you have the teeth, and we cross the finger that everything will go, okay? Or we extract, even if it's healthy, the second premolar, we do a post-extractive implant there, and we put a pterygoid implant posteriorly. I offer to the patient the 2 solutions. Guess which solution the patient chose? The second one. So I extracted the second premolar, I put the pterygoid implants, and in 25 minutes of surgery, I solved the situation. And I did it 8 years ago, 9 years ago, and it's still working. And you know why I'm still working? Because I'm using the tissue and the bone of the patient. Okay? So, nothing fancy. Let's see some pictures from the cadavers, because from this specimen, because we have to know the anatomy also from the cadaver lab. Why? Because from cadaver we understand much more better the anatomy. So tuberosity, okay? Then that wall is the posterior wall of the maxillary sinus. It's a lamina, like the floor of the orbit, like Matteo was saying. It's so soft, with a finger you can fracture the bone. And look where is the pterygoid fossa. The pterygoid fossa is more medial. Always more medial, okay? So, and this is the osteotomy. The osteotomy is always the same, from mesial to distal, and from lateral to medial, okay? Remind it, that's why I'm repeating it many, many times, because it's the first secret of pterygoid, the inclination, and then the feelings when you do the osteotomy, okay? So, from different point of view, you see, and now I'm adding something more that you have to remind, the drill, tuberosity. Between the tuberosity and the pterygoid fossa, I told you there is the pyramidal process of the palatine bone, okay? But, going deeply inside this anatomy, between the tuberosity and the pterygoid fossa, we have this incisura. This incisura represents the floor of the pyramidal process. And the pyramidal process, like I told you before, represents what? Our target point, where the implants get stability. Okay? Remember it. Remember the incisura, because the incisura, it will be our eyes in this planned surgery. Okay? Then finally we put the pterygoid implants. How JD pterygoid implants are designed? They are designed with a rough part in the body in order to have osseointegration, and a smooth part in the first 4 millimeters. Why we have this smooth part? Because we expect to have bone resorption in the tuberosity, okay? Because sometimes there is some cells inside the tuberosity. Sometimes we don't find anything, okay? That's the truth. Maybe there is only fibrous tissue. Maybe there is a lack of vascularity inside the tuberosity. That's why we expect to have about resorption there. That's why we designed the implant with a smooth surface in the collar in order to reduce the risk of what? Of periimplantitis. Okay? So, this is the implant in place from different point of views, but look, I'm really proud, and I always say this thing in every congress and every course. This is the best picture that I have taken in my life because it represents what we do every day, what we have been lecturing about the last 10 years, the concept of the remote anchorage, like people says, or this primary stability, or the bicortical anchorage. Okay? Low density bone, the tuberosity, nothing inside. The apical part of the implant anchored where? Into the cortical bone, like with nasal implants, like with zygomatic implants. Okay? That is the concept of immediate loading. Starting from a zone that has a low density, going through a zone where we have a high density bone, and ending inside a fossa or another place. Okay? Is it clear? Good. And look where is the artery. Look where is the artery. The artery is there. Okay? You see, it's very far. More than 4 centimeters. So we have not to be afraid about the artery. We have also published with our friends, for example, with Tommaso, with Rawad, that is another friend from Lebanon, about pterygoid implants. And you know which is the survival rate and success rate of pterygoid implants is similar and better of normal implants, of the normal intraoral implants. They work very, very good. And trust me, they work very, very, very good. And I can say it, Matteo can say it, other surgeons that I know that they are very skilled inside this room, they can say the same thing. Pterygoid implants, they work very, very good. Okay? So, now let's go deep inside the surgical technique, because now we know the anatomy, we did the cadaver course, we know everything, so now we have to put the pterygoid implants, okay? Because there are different surgical techniques. And now, before I show you a really interesting surgical technique, uncovering the medial pterygoid lamina, okay? I'm going to show you something different and some tools that they help you raising less invasive flaps, okay? So, let's see how invasive is a pterygoid implant, because many people think that pterygoid implants are invasive surgery. Think about that. I do every full arch under sedation, but this kind of surgery are not under sedation, only using the local anesthesia, because the less than this, you cannot do anything, okay? So, I raise a flap starting from the distal aspect of the tuberosity. Then I perform my osteotomy with the specific pterygoid kit at 300 RPM without water. Why 300 RPM without water? Because I want to feel with my bar and my motor what I'm doing. And then, after having done the bicortical anchorage, I put my implant by hand. Why by hand with this hand surgical driver? Because I want to feel what I'm doing. I want to feel with my finger, and finger are the most important guide that we have. The increasing of the torque, because the torque is like a GPS. When we put an implant and we feel that the torque is increasing, it means that we are anchoring and putting the implant in the right spot. And also have the perfect control, because with the torque wrench we can change the inclination. And putting the implant inside the 10-15 millimeter inside a really soft bone of the tuberosity, we can catch the wrong path. Okay? Is it clear? If it's not clear, I repeat it. Okay. So this is the healing, and you see all the healings are like that. Why all the healings are like that? because I'm Zucchelli? No, because I'm following the biology. Okay, I'm using the multi-unit abutment, that is the element that permits to our rehabilitation to last several years inside the mouth of the patient. So I'm putting the multi-unit abutments directly after the surgery, following the one-time, one abutment concept. I let the connective tissue to heal around the multi-unit abutment without any problem. Okay? And I can deliver an immediate definitive rehabilitation, an immediate loading rehabilitation, and finally with full zirconia bridge. Okay? And look, I took this CBCT after a while because I had to do other surgery. Look, the behavior of the pterygoid implant. The tip is kissing the pterygoid fossa. Here, luckily, we didn't have any kind of bone resorption. Everything is in place, everything is stable, everything is working very, very good. Okay? With a low invasive solution. Really low invasive solution. So, let's analyze the surgical technique. Presenting you this clinical case. Look at this clinical case. Okay? I had this patient that wanted to maintain the frontal teeth. Okay? Can be a mistake, can be not. I think that was a mistake because it would be better to do a full arch. Anyway, 5 years ago, I wanted to rehabilitate the patient with 2 partial rehabilitation posteriorly. Let's analyze the case. I had some bone here, some bone here. I had no bone here. So 2 solutions. Or I do a sinus graft, but you know, sinus graft, and I love doing them, they work if I have a normal sinus, not a wide sinus. Because wide sinuses means lack of vascularization in the middle of the graft. And lack of vascularization means a failure. Okay? And I don't want to have failures in my office because I'm selling treatments. I'm not in a hospital. I don't want to be judged for my failures. So I want to reduce my failure at minimum. Okay? Let's analyze the CBCT. We have 2 beautiful tuberosities, very large. And look, between the tuberosity and the pterygoid fossa, we had this white bone. This white bone represents what? The cortical bone that gets anchorage and stability to our pterygoid implant. Okay? Is it clear? Good. So, what do? I raise a flap, really low invasive flap, but the trick is to start behind the tuberosity. And why I want to start behind the tuberosity? Because I want to touch. Do you remember that I mentioned the incisura? The incisura between the tuberosity and the pterygoid fossa that represents the floor of the pyramidal process. Okay? The incisura is telling me, Filippo, if you follow me, because I'm between your starting point and my ending point, you'll put the implant into the right spot. Okay? So, without raising a big flap and putting an elevator behind the tuberosity, I had a guy in a blind surgery. So I could put an implant very easily, and I always put 70-degree MUAS, 70-degree multi-unit abutment directly toward vestibular. Why? Because I want to make my life easier. To unscrew and unscrew, scan body, transfers, and the rehabilitation. Okay? I want to reduce my stress because I'm a stressed person. We are always stressed during our days. So our goal is to reduce our daily stress. So we have to make our life easier every time. And with general care, for example, for pterygoid, we have this long screwdriver that can permit us to screw and screw the multi-unit and the rehabilitation from outside the mouth in order to reduce the risk of the fall of the screw and the screwdriver inside the throat of the patient. Okay, this is the final surgery. Okay, look how invasive it was, this surgery. The final OPG and the final rehabilitation, titanium composite, because the patient wanted to save some money, wanted a cheap rehabilitation. Okay, cheap, but it doesn't mean low quality. Okay, remember, because in my opinion, this kind of treatment nowadays is the best treatment that a patient can have. If I would choose in my mouth, I would prefer to have a pterygoid implant and a straight implant like that, and not a bone graft, even if I do bone graft when I am obliged. Okay? So, following this surgical technique, following the incisura, 3 years ago, I had this idea that I shared with Giacomo and Jay Dental Care, and all together we developed this tool that is the only guide in the world available in the market that permits us, first of all, to elevate the flap in the posterior area, and second, to be guided in pterygoid surgery. Okay? Because many colleagues, they were saying to me also during courses or during practical courses, oh Filippo, I don't know, I understand the anatomy, but I feel stressed when I work in that area. So why not to design and develop a simple tool, a simple instrument, okay, for a freehand guided surgery, not only for freehand we are going to see, but why not? So let's see. And let me to explain this tool with a video. The first day that JT sent to me this tool, because we designed it in a very simple way, but anyway, I designed it, they sent to me a try, and I had this case. I had to put some implants here and a pterygoid posteriorly. So I told to myself, why not? It's the perfect clinical case for putting and trying the JD Pterigo retractor. Okay, let's see the video. So first of all, I raise the flap, a crystal full thickness incision from the distal end of the tuberosity. Then I raise the flap, full thickness, very easy, a crystal flap. Okay. Then with the elevator, I probe, I feel the incisura behind the tuberosity. So I take my retractor, the JD Pterigo retractor, I put it behind the tuberosity, you see, I put it behind, it reflects the flaps, it makes order in this surgical field, I move it and I feel that it's stable. The pterygoid retractor has a line, a laser marked line that guides me toward the pterygoid fossa, like the Malo guide. Do you remember the Malo guide for all of four? It's the same. Do you see the laser mark that is 30, that 20 degrees toward middle? I stay parallel to this laser line, and being parallel to this laser line, I'm 100% sure that I'm going toward the pterygoid fossa. Okay? How easy it is. How easy it is. Okay? A connective tissue graft is much more difficult. Okay? So I drill 300 RPM without water, always maintaining my retractor in place, following the laser vertical line. Okay? And then I place. I follow the using the kit, so we have 2.0 bar, 2.4 bar. Why 2.4? Because maybe tomorrow in the workshop we are going deeply inside the features of pterygoid, because the tip of the implant is 2.4, and then we enlarge at 3.2 the most coronal part in order to avoid fractures. And then by hand, and look, I'm always parallel to the vertical line. By hand, I put my pterygoid implant, obtaining a high, really high, sometimes too high primary stability that permits me what? Immediate loading. Okay? So let's see some picture. You see the vertical line, the marked stamped vertical line. Okay? The angle, the face of the instrument of the JD pterygoid retractor is pre-tilted at 20 degrees. Okay, so following it, I'm inclined from lateral to medial, more or less 20 degrees. You can complain, okay Filippo, but how can I be sure to be inside the pterygoid fossa? Because the pterygoid fossa is large, okay? And if I am a little bit more medial or a little bit more vestibular, it doesn't matter. Because if I follow the line, I'm inside the pterygoid fossa. Because the pterygoid fossa is large, it's large. 1 centimeter more or less, because I measured it in more than 100 CPCTs and more, okay? And this is the final CPCT of the previous video, and you see a 20 millimeter implant kissing what? The pterygoid fossa. Easy, really, really easy, because I want to make my life easy. I want to go and to do my surgery without being stressed, okay? I want to do it following protocols and not thinking too much of what I'm doing, okay? So, review how we use the pterygoid retractor. Flat, okay? Distal end of the tuberosity. This is the retractor in place. We stay parallel to the vertical line. The laser mark that is stamped over the face of the instrument. Okay, you see it retracted flat. This is the osteotomy. We are parallel, and finally we put the implant. Okay, so it's a sort of guide. It's a sort of guide. So let's see from this picture. Okay, we have to put the instrument where? Behind the tuberosity. The instruments have two teeth that they are blocked in the middle aspect of the incisura and the lateral aspect of the incisura. Okay? Then, following the laser mark on the instrument, my implant will end inside what? Inside the pterygoid fossa. Okay? Is it clear? We are going to see some videos. So, now we combine what I said this morning about the full arch digital protocols and the surgery, because it's a circle, okay? Because in my office and almost everywhere I do the surgical part and I do also the prosto part, because I love both. So let's see this case. This was a patient with a terminal dentition, so I planned to put 2 tilted implants in the premaxilla, 2 actual implants in the front, and 2 pterygoid implants posteriorly. Okay? So I always take pictures because I want to study, to remember the treatment plan, partially generated treatment plan. So I combine, interpolate what? Pictures, intraoral scans, and the radiographic data in order to establish my treatment plan. And then I move into the surgery, okay? So let's see the surgery, okay? So I raise a flap always from molar to molar. Then it's very important to do an osteoplasty, to clean the bone, to see very clear on the surgical field. With genital care we have this full arch kit where you can find all the bars that they are useful. Then I start with the pterygoid. So you saw with the elevator, I raise the flap, I probe behind the tuberosity, and then I put my JD pterygoid retractor. With the JD pterygoid retractor, I'm sure that I'm guided. So I start with the pilot drill. The pilot drill is like a probe. Okay? So I enter inside the tuberosity, I feel something hard, then I stop. Then I take the 2.0 bar from the pterygoid kit. I go 300 RPM without water. I feel hard. If I'm not sure, I probe. I feel that I'm inside the bone envelope. Then I reactivate the drill, okay, going against the cortical bone, and suddenly I fall inside the pterygoid fossa. So remember, soft, up, and then I fall down, okay? See, I'm going slowly, 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 in order to feel everything. And no water is not risky because the temperature and the overheating of the bone is directly correlated to the pressure. So I follow the protocol 2.0, 2.4, and then I use the 3.2 bar in order to enlarge the most coronal part, and I put my pterygoid implant free hand. Because I have the perfect inclination of the implant, I don't change the path, I don't change the inclination, and with my finger, I feel the torque, okay? So you see, it's very, very easy. And at the end, usually you get torque in the last 2-3 millimeters. So, opposite side, I don't care about the anatomy, because with the pterygoid retractor, I don't care if the fossa is too medial or too lateral. Sometimes it's more lateral, sometimes it's more medial. Because putting the retractor behind the tuberosity, touching the incisura, it always tells me where I have to go. Okay? So I reduce my stress. And when the implant is getting stability, kissing the pterygoid fossa, it gets torque. Then I move anteriorly. Now it's famous this protocol that is called PATSI. PATSI, what does it mean? First of all, you put the pterygoid, then you move anteriorly. Because pterygoid can change the solution of the case, okay? Avoiding, for example, gonzygoma, that they are really difficult, you must be really skilled, okay? So, always I do big cortical anchorage, then I always use the bone track drills. I'm in love with them. I've been using them since they were in the market because they prepare the coronal part having and giving me the perfect prosthetic axis, okay? And then I put my implants. I put my implants, okay? I'm using the conometric implants. I'm using this Zappa tool. Also, Matteo showed you. It helps you to choose the MUA and to put the implants in a perfect prosthetic position. Okay. Now I'm using the bone track for the palatal approach, but I have another video that permits us to go deeply inside the palatal approach. Big cortical anchorage anteriorly. Okay, bone track drill, so leaving under prepare the apical part for primary stability and prepare the same diameter of the implant, the coronal part, for having the perfect prosthetic axis. And look at the long screwdriver. Look where I'm working. I'm working outside the mouth. So now you know the photogrammetry better than me. Then I screw the scan body. I take a scan, I stitch, I take the photogrammetry, and then I move into what? Into the digital rehabilitation, okay? So let's move on. This is the final OPG, all the implants with a big cortical anchorage. This was the provisional. This, you know why? I didn't tell you this morning that I put two tracer, two reference in the palette. Why? Because putting only one, we can have a bending of the occlusal plane. Like in this case, this was one of the first clinical case to did using and following a digital workflow, and you notice that the occlusal plane was wrong. Okay, nowadays I'm skipping this problem, I'm overcoming this problem, putting two tracer, two reference point in the palette. And this was the healing, okay, always the same because we use the multi-unit abutment, and I rehabilitate the patient, you know in which material, in metal ceramic. Why? Because I didn't have what? Enough prosthetic space. You remember this morning, I was stressing this boring concept about prosthetic space. But remember, I want to live for reducing my stress. So we have to know the materials. If I would rehabilitate this patient that is a bruiser, I'm also rehabilitating the inferior part I can have problems with fractures of the material. That's why having not a lot of prosthetic space has to the dental technician. Why don't we rehabilitate the patient with a metal ceramic? And this is the final framework, okay, delivered with photogrammetry, very precise. This is an FP2 rehabilitation and the face of the patient before and after, okay? Good. And look, why I'm in love with the pterygoid retractor? Because pterygoid retractor guides me also in difficult cases, okay? Like in this case, look how much difficult was these pterygoid implants, because it had to be really vertical, okay? And we had a really narrow pyramidal process. This is a tricky pterygoid implant. But being guided by this tool, I was able to put these pterygoid implants, that it was a 24 pterygoid implant, without any concern, having a really good primary stability and delivering to the patient this zirconia bridge after the healing. Okay? So you understand that I'm not guessing my inclination. I wasn't born with amazing skills. I want to make my life easier. That's why I'm using this guide that, thanks to the company, we developed together. Okay? And why pterygoids are important? Look at this clinical case. I did this pterygoid in 2017 when we started with pterygoid implants without knowing perfectly the surgical technique. And 3 years ago, the patient asked me, Filippo, can you do the same on the right quadrant? Why? Because patients, they don't remind the pterygoid surgery like a painful invasive surgery. They remind the surgery like a low invasive surgery. And I had a really narrow tuberosity. So 3 years ago, I spoke with myself and I said, Filippo, you are not trained in guided surgery. You have to learn guided surgery. Why don't you start with this case? So I asked to the company the software. They gave me the real guide. So I planned my implant, okay, or a guided surgery. So I did my surgical mask. For this kind of surgical guided surgery, they are easy to plan, really easy. You are guided. So I stamped the surgical guide, and then I did with the classical surgical guide. I'm approaching and I'm doing a semi-guided approach. What does it mean? That I use the guide only for the first osteotomy. Why? Because the tuberosity usually is very thick, more than 5 millimeters, and the offset of the sleeve usually is calculated with the driver of the implant at 5 millimeters. So sometimes you have to increase the height, the length of the offset, and increasing it, you don't have the driver of the implant that permits you to put the implant in a completely guided way. So I use the guided surgery, okay, for the first osteotomy. Then I raise the flap. I finish my osteotomy in a freehand way, but it's easy because I'm guided from the first osteotomy, and then I put my implant freehand. Okay? You understand? It's important to understand because now I'm going to show you a development of the guided surgery. 70-degree MUA directly toward vestibular in order to make my life easier. The healing, always the same. Look at the healing of the right side, okay? After more or less 7 years, it was perfect. It's perfect also this. So I took a scan. Remember, in short span, the intraoral scan is very precise. So I can use only